Good morning, donkeys. How are you guys doing? Hopefully, you've had a pleasant week so far. Just want to review a little bit with you and talk about respiratory failure, some of the things we've been talking about for the last couple of days. Also, want to go ahead and today we're going to discuss the classic Shunt equation, and then we're going to talk a little bit about ventilatory or hypercapnic respiratory failure. First thing I want to mention to you guys as a reminder, respiratory failure, there's two major categories, acute and chronic. Acute means that it's happened in a very short period of time ago. Chronic is something that we have patients who live in respiratory failure. And these patients are basically your patients with COPD or your patients who have neuromuscular disorders. The objective value to determine whether or not a patient is in respiratory failure is going to be your ABG. And your ABG, we're going to look at your PaO2 and we're going to look at your PaCO2. Hypoxemic respiratory failure, which is one kind or type of respiratory failure, the PaO2 is less than 60 millimeters of mercury on room air for a healthy person. The second type, which is or kind, is ventilatory or hypercapnic respiratory failure. This is your PaCO2, and it's greater than 50 millimeters of mercury for a patient who's breathing room air, a little bit higher, around 55 for patients who have COPD. P big AO2 is always your alveolar oxygen. This is what's available in the alveoli. This is how much oxygen is now available to diffuse out of the alveoli into the arterial gases at this particular point. P little AO2, of course, is always arterial oxygen. Normal for this is about 80 to 100 millimeters of mercury. Again, anything less than 60 millimeters of mercury on room air is considered hypoxemic respiratory failure. The thing you want to remember is when you guys learned about ABGs, there are 3 levels of hypoxemia. Anything less than 60 is considered moderate hypoxemia. We also talked about this in therapeutics, that documented hypoxemia was a PaO2 less than 60. All of this comes together to tell us that if your PaO2 is less than 60 millimeters of mercury, especially on room air, your patient has a hypoxemic respiratory failure. We also can look at what we call the A to A gradient. This is your P big A minus your P little AO2. This is the difference between what is available diffused and what actually diffused. When you look at the answer, though, for the PA minus AO2, that is how much has been left in the alveolar spaces, okay? So we're going to take the alveolar that we had, subtract the arterial from it. What's left over is now what's remaining in the alveolar space at that particular point. Remember, with your A to A gradient, we have norms. These norms are based on age. The normal on room air is 10 to 25 millimeters of mercury. On 100% oxygen, the normal is 25 to 65 millimeters of mercury. And the question comes up is, why do we really care? What is it that, why is this important to us, you know? Basically, it's because of this. If you have a patient who has an A to A gradient of 250 millimeters of mercury and they're on 50% oxygen, they're not close to being anywhere near normal. This should trigger a little bell in our head to say there's a problem with this patient. We need to go check and find out what's going on. The other thing you want to remember, if the A to A gradient on 100% oxygen is greater than 350 millimeters of mercury, this is an indicator for support. We either need to mechanically ventilate them, we either need to put them on CPAP, BiPAP, or we're using quite a bit the high flow nasal cannulas. In order to come off of this support, the 350 has to be less on 100% oxygen. So there it is. The difference again is what's left in the alveoli. The difference is not what what did not diffuse. And so I have my little drawing down here with my little drawing. Let me see if I can get my little pencil to work. Okay. What happened is that we initially started with 350 millimeters of mercury, okay? What happened then is that we went ahead and we diffused 80 millimeters of mercury of oxygen through the alveolar capillary membrane into the arterial spaces. When that happened, that left 270 millimeters of mercury sitting in the alveoli. When this patient goes ahead and exhales, he's going to exhale that 270. The next breath coming in, because he's on supplemental oxygen, again, it's going to be 350 millimeters of mercury. If everything stays the same and there's no changes, then he's probably going to still diffuse that 80 millimeters of mercury. He's still going to have that 270 that's left over, and then he'll go ahead and exhale it at that particular point. We can also look at the A to A ratio, and that's your P little AO2 over your P big AO2. And it's the ratio of what's in the artery compared to what's in the alveoli. This is a formula that sometimes people will tell you, well, yeah, it's a good formula. No, it's not a good formula. The nice thing about this formula, at least gives us something to take a look at with our patients to help us determine, are they okay? Do they have a VQ mismatch or do they have a shunt? Now you want to remember that if you have a VQ mismatch, if we give you oxygen, we should see an increase in that PaO2. The normal value for your A to A ratio is 0.74 to 0.90. Anything less than or equal to 0.60 is a VQ mismatch. Anything less than or equal to 0.15 is a shunt. What's between 0.61 and 0.73, you're fairly normal again. Remember, this is also based on your age at that particular point. Now, this can be sometimes used as a 75% to 90%, 60%, 15%. A lot of times, though, in the literature, when you see this, it's not a percent. They leave it as a decimal. Much, much easier to work with at that point. A simple way of estimating what your PaO2 should be is to use 5 times your FiO2. In this case, probably about 4 or 5 years ago, Teresa and I were talking. We had heard this. People had been talking about this. There was this formula that existed. We went ahead and we did some research in the literature. We finally found the physician that talked about this. And what the physician basically said is if you take your FiO2, multiply it by 5, it gives you an estimate of what your PaO2 should be. If you use 21%, which is room air, times 5, you're going to come up with 105. We know that at a barometric pressure of 760, which is sea level, that's 100 millimeters of mercury. So you're just like 5 off, which is not a really big deal. If you have a patient, though, who's on that 50% oxygen, 50 times 5 is 250. That's where his PaO2 should be. And if you notice when we did the drawing that the PaO2, little AO2 is actually only 80. At this particular point, we can also look and say there is a problem. He is way below where he needs to be. The classic shunt equation. This is probably the best formula that we have for figuring out the efficient use of oxygen. The problem with the classic shunt equation is in order to get the CVO2, this is the content of mixed venous O2, we have to have a catheter in the pulmonary artery. The catheter in the pulmonary artery is either your Swan's-Ganz, or you'll see it also just labeled pulmonary artery catheter. We're not doing quite as many of those as we used to. Part of the reason is that we don't want to make holes in people because that allows infection to set in. However, we still do use part of this, and so we still teach it because it's still a very valuable formula for us. So the classic shunt equation is basically the amount of cardiac output that's shunted compared to the amount of cardiac output that was put out. And the various parts of it are the CCO2, the CaO2, and the CVO2. When we look at these, the definitions of these parts are the CCO2 is the O2 content of alveolar capillary blood or end content of blood. You'll see it written both ways. C little AO2 is the content of arterial blood, of oxygen in arterial blood. CVO2 is the O2 content of the mixed venous blood. These answers for this are expressed in millimeters of oxygen per 100 milliliters of blood, or the shorthand, which is vol%. And the formula for all three of them are the same formulas. The formula, if you recognize it, is based on the way that oxygen is carried in the blood, okay? And we can see you have a little X up here. That little X either means alveolar, arterial, or venous. It's going to be the same formula for all three. So remember, oxygen is carried in the blood, either dissolved in plasma, and that's your PaO2 times your 0.003. Remember, PaO2 is a minor player in this. And it's a minor player because it doesn't really make that much difference or that much change in what's happening. But we still need to know because it also affects sometimes how much oxygen we can bind to hemoglobin, okay? So the majority of your oxygen in the body is carried as bound to hemoglobin. And that's 1.34 times the hemoglobin level times the SVO2, whatever the formula that we're working with at that particular point. A player in this, probably one of the major players is the hemoglobin, and a second major player in this is going to be whatever your saturation is. If you have a low saturation, even with a good hemoglobin, you're going to have a low content of oxygen in your blood at that particular point in time. So what are the norms, basically? And this came back from way back when. The normal in content or alveolar oxygen is around 20 vols%, okay? Your little AO2 is somewhere around 16 to 20 vols%, and the CVO2 is somewhere between 12 to 15 vols%. And these are the normal values that we base what we're doing on. So there it is, CCO2 and capillary O2 content or alveolar O2 content. This is what is available in the alveoli. As a result of this, when we do this formula, one of the things that we take into account is that the saturation of oxygen in the alveoli is 100% saturated, okay? As a result of that, you see where the 1 is on here. Let me grab my little pointer here. Let's see if my pointer's going to work. This is my highlighter. There we go. Anyways, this little 1 here is your big AO2, and that 1 represents 100% saturation. So the FiO2, if you were to look at it, would be 1 at this particular point in time, okay? So sometimes when we do this formula, we just remove this and just use the 1.34 times the hemoglobin. Then we have to remember to go ahead and use the P big AO2 since we're talking about alveolar oxygen times the 0.003. This is probably this actually is one of the areas that we have problems with when we do these formulas because we forget that the end capillary or the CCO2 is in the alveolar area, okay? Little AO2 is the arterial content of O2 of oxygen. This is what you have at this particular point. This is what you're going to be sending out. You can only send out what's been diffused across the AC membrane. In this case, the formula is basically the same formula, but what we're going to have in the place of the S big AO2 is the small s little AO2. Remember, S little AO2 is a percent, okay? When you get that on your ABG slip, it is a percent. And we have to turn it into a decimal, okay? Remember that sometimes hemoglobin is reported as grams percent. That is still a whole number, okay? The only percent in this formula is the SaO2. So we're going to use the 1.34 times the hemoglobin times the SaO2, and then we're going to add that P little AO2 times the 0.003. That is going to give us the arterial content of oxygen. CVO2, the little line over the V, means a true mixed venous. Remember again, the true mixed venous comes from the pulmonary artery. The pulmonary artery is the only artery in the body that can give us a true mixed venous. And remember, when we're dealing with these, because this is a shunt equation, the patient has to be on 100% oxygen. So in this case, then, if we don't have a true mixed venous because we don't have a catheter in place, we're pretty well stopped at this point. But I'm going to show you in a few slides some of the things that we can substitute for this. But you still need to know that the true mixed venous comes from the pulmonary artery. Pulmonary artery or Swan-Ganz catheter has to be in place at that particular point. When we look at the formula for the PVO2, and I put it on this slide here, it's still the 1.34 times the hemoglobin times the SVO2, and there's your percent, plus the PVO2 times 0.003. And what I'm showing on this slide, hopefully, at this particular point, let me grab my pen again, and I'll grab my red and go up here, is that the P big AO2 is up here at this particular point. This is what's going to be available, okay? And I want to know what that content is. 1.34 times the hemoglobin plus the P big AO2 times 0.003. What I'm looking down here, this is where the oxygen is diffused across that alveolar capillary membrane. And then as a result of that, now we have our P little AO2. As a result of the P little AO2, here's my formula, 1.34 times hemoglobin times SaO2, again as a percent, plus P little AO2 times 0.003. This is going out to the body in order to supply oxygen to the tissues. What happens over on this side over here, the blood is now coming back into the pulmonary artery. As a result of that, now we're looking at what's left in the venous blood at this particular point. And what we get that value. We're going to plug it in here, the 1.34 times the hemoglobin times the SVO2, again as a percent, plus the PVO2 times 0.003. So this is just a complete circle that continues on when we're trying to measure the shunt at this particular point. So the question then comes up, what does all of this mean? We talk about shunts. We've been talking about shunts, and we've said, well, you know, we have an anatomical shunt of 2 to 5%. We talk about a definition of shunt, perfusion without ventilation. Really, you know, what is this? Does it really have a meaning? And the answer is yes, it does. When we're talking about a shunt using the QSQT, norm is less than 10%, okay? So when we have the catheter in place and we've actually gotten our mixed venous blood and we've been able to measure our actual QSQT, the normal for this is going to be less than 10%. A mild shunt is somewhere between 10 to 20%, okay? And I'm going to come back to this in just a minute. So if you're somewhere between 10 and 20, that's not terribly bad, but we're still going to worry about you quite a bit. A significant shunt, anything between 20 and 30%. And then the last, a very severe critical one, is anything that's going to be greater than 30%. This is where we have some major oxygenation issues going on. There is an indicator for support here. The indicator for support for the QSQT is anything greater than 15 to 20%. Okay, let me repeat that again. The indicator for support for the QSQT is between 15 to 20%. To come off of support, you have to be less than 15 to 20%, okay? So the indicator for support with the QT is 15 to 20%. Coming off of support is less than 15 to 20%. So because I mentioned to you that we're not doing as many pulmonary artery catheters or Swan's GANs, we've actually come in and modified the shunt equations. It was interesting. I was reading an article a couple of years ago and actually came across this, and I thought, whoa, this is really, really cool. I want to share this because eventually this is going to end up in the books also. So what we do with this is, for the most part, we're going to still use what we do have available to us. And if you notice, we still have the CCO2 and we still have the CaO2. Well, what we're going to do is we're going to go ahead and substitute for normal lungs a +5. And where does that +5 comes from? It comes from, and you're going to see this on a slide coming up on my board slide. It's the difference between the little AO2 and the CVO2. This is normal. So you're going to go ahead and do your subtraction, add your 5, and then divide it into the CC minus CaO2. For critically ill patients, because especially with ARDS, we know that their lungs have some issues and we have a hard time, making sure they're oxygenated as well as they need to be. Instead of the 5, we're actually going to use the 3.5. And so in this case, we're going to take the difference between the CCO2 minus the CaO2, add the 3.5, and then divide it into the CCO2 to the CaO2, okay? What I would like you to do, if you're making yourself a formula sheet and to take it with you, make sure you put these formulas in there. I would not be surprised if you hear about them when you actually go to your clinicals, because like I said, we're starting to use these formulas simply because we don't have the mixed venous blood that we'd like to have. So there's the formula, Ca minus VO2, and the difference is 5%, 5% rather, and that is expected to be normal. When you get into 5th semester, Tammy during hemodynamics is going to talk about what affects this. And one of the things that affects this is your cardiac output. If it's increased or decreased, is going to have an effect on it. And then the amount of oxygen that's actually being used by the tissues is another thing that affects this. So there it is again. CaO2 minus CVO2, difference between what we've sent out and what is being returned. The norm is about 5%. Now, this is something that came up on a board question years ago, and it has not been taken off the board. The question basically, what is the best measurement of oxygen used in the body? And most people will tell you at the beginning, well, that has to be the PaO2, the little arterial O2, because that's where the oxygen is and it's being sent out. Well, the answer is no. It's going to be your venous side of the house, because remember, P little AO2 is what we're sending out. We don't know how much is going to be used until we get the venous side of the house back. So the answer to what is the best measurement of oxygen use in the body, we're going to look at either the PVO2 or the SVO2. A normal PVO2, this is one of the figures that you're going to get from Teresa and I. We use the same numbers. PVO2 is between 38 and 42 millimeters of mercury. A normal SVO2 is about 75%. So this is what we base this off at this particular point. A lot of times, though, if you see this on the boards, they're not going to give you the values. What they're basically going to just ask you, what is the best measurement of the use of oxygen in the body? And the answer is how much has been used is going to show up in the PVO2 or the SVO2 at this particular point. Okay, so that's basically the oxygen side of the house. And one thing you want to remember, when you're talking about oxygenation, you're only looking at the formulas and the information that affects oxygenation. For example, if it asks you in a question, which of the following is an indicator of problems with oxygenation, and they give you PaCO2. PaCO2 is ventilation. And because PaCO2 is ventilation, it is not part of that answer. So remember, oxygen goes with oxygenation, okay? And it's important for us to remember that. The other side of the house is the acute hypercapnic or ventilatory respiratory failure. The books have changed enough to where ventilatory is now taking over hypercapnic. They actually mean the same thing. Remember, hypercapnic means high levels of CO2, greater than 45 millimeters of mercury. This is your pump failure or the ventilatory failure, okay? You've got the oxygen out. Doesn't necessarily mean it's going to be a good oxygen that's coming out, because you can have both hypoxemic and hypercapnic respiratory failure going on in the same patient at the same time. The difference is it's not coming out of the lungs. The problem is not the lungs. The problem is the delivery mechanism. And anyone in hypercapnic respiratory failure has an elevated PaCO2. This is the reason why, if you remember, I told you at the beginning, we have folks who live in chronic respiratory failure. These are the patients who have elevated CO2. These are the patients who have COPD. These are the patients that are some of your neuromuscular patients. So looking at the formulas then, or definitions, let's put it that way, one of the things that sometimes people have a problem with is, what kind of ABG are we now going to see with someone who lives, or really either lives in chronic respiratory failure, or is an acute respiratory failure, or has an acute condition planted upon their chronic condition? The ABG in all three of these cases is basically there's going to be a respiratory acidosis. The difference is with a compensated for patients who have chronic respiratory acidosis or chronic hypercapnic respiratory failure, it's a compensated respiratory acidosis, okay? That's where that difference comes from. So what do we see when we see the ABGs of patients who live with chronic respiratory failure, or patients who have COPD, or patients who have a neuromuscular disorder? We see a pH that's going to reach about 7.39. It is not going to get above 7.39 unless there's an alkalotic issue going on, and we're not going to really deal that much with the alkalotic issues, or there's a mixed problem. And now we have both a respiratory and a metabolic problem that has brought that pH up to 7.40, okay? We're also going to see the elevated CO2, because remember, an elevated CO2 is acidotic. We're going to see the compensation mechanism for that elevated CO2 is a metabolic alkalosis, okay? And what that basically means is that your bicarb is going to be elevated to try to and compensate for that elevated CO2 to be able to bring that pH back into the normal range. And so that's what we're looking at. Remember also, when we talked about electrolytes, we said that chloride and bicarb are inverse to each other. If your bicarb is going up, your chloride has to go down. Why do we care about that? When we're doing our ABGs and we do our electrolytes and we see an elevated CO2 with a decreased chloride, we can pretty well speculate that this patient either has COPD or they have a neuromuscular disorder, that they live in chronic respiratory failure, okay? And that's a way that we can go ahead and then start working as to what we're going to do at that particular point in time. We talked about alveolar minute ventilation. Remember, alveolar ventilation and CO2 are inversely related. And sometimes it's hard to say, well, let's try to take a look at this and see what are we really talking about. And what we're talking about is this. In order to get rid of CO2, you have to be breathing. Remember, the correction factors for any ventilatory problems is your tidal volume, your respiratory rate, your minute ventilation, okay? So you have to have a good tidal volume, you have to be breathing and getting rid of the CO2, and that will keep things in balance for you. Once you start picking up more dead space, your alveolar ventilation is going to decrease. Because your alveolar ventilation is now decreasing, the CO2 is going to increase. The relationship, as you can see with this, if you double the CO2, you're going to cut your alveolar ventilation in half. Okay? So that's one of the concepts that you need to make sure you understand. The relationship between minute alveolar ventilation and PaCO2. The next thing you see on this slide is how can we estimate PaCO2? You know, we have some information. We know what the patient's minute alveolar ventilation is. We know that because we measured it. We knew what the minute ventilation was before we did their ideal body weight, and we took it off as dead space. How are we going to figure out how to get the PaCO2? This is the formula that goes with it. Now, what you're seeing at the beginning of the formula, 0.863, that's a constant. All right, it's not going to change. And then we're going to multiply it by that VCO2. Remember, VCO2 is the amount of CO2 being produced from the amount of oxygen that's being used, and it's part of that respiratory quotient, which is 0.8. And so we can go ahead, once we know what that is, and plug it into our formula. And as a result of that, now we can predict what the PaCO2 would be for this patient at this particular point in time. This is another formula that I want you to plug into your formula sheet. Take it with you. When you come back in 5th semester, who's teaching advanced mechanical vent is going to hit upon this formula again. So if you remember, and I'm going to just bring these up here, when we talked about hypoxemic respiratory failure, we said that there's mainly 6 causes that can cause us to have hypoxemia. One is the decreased inspired oxygen. We see this with our patients who have COPD. Another one is mountain climbing to the top of the Himalayas or even the White Mountains here in Arizona. Another one is a perfusion-diffusion defect, and another one is a diffusion defect. These exist in part of life, okay? The shunt, the VQ mismatch, and the alveolar hypoventilation, those are the major 3 that we focus on when we're dealing with respiratory failure. So there's the 3 major ones that we talk about with hypoxemic respiratory failure. When it comes to either ventilatory or hypercapnic respiratory failure, we have 3 causes of that also. So we're looking at 3 and 3, and as we go on, we'll pick up some more 3s down the line. The first one we're going to talk about is decreased or depressed ventilatory drive. If you remember when we used to talk about oxygen, giving a patient who had COPD and sometimes our neuromuscular patients too much oxygen, we decrease their drive to breathe. And normally when that question shows up, people go, oh my gosh, I don't remember. That was back in 2nd semester. Did we really ever have a 2nd semester? Or did we just go from the school into 3rd semester and now we're in 4th semester? Well, I hate to inform you that yes, you did have a 2nd semester. What we do with that, remember, is that we're going to go ahead and lower the oxygen that the patient is getting. And then sometimes they'll ask you to do an ABG, other times they won't. Our pulse oxes are fairly reliable once we get everything worked out. The only thing my pulse ox is going to tell me about is your hypoxemia. It tells me nothing about your CO2 as far as that goes. This is what we're going to talk a little bit more about, though, when we talk about decreased or depressed ventilatory drive. This is something that's wrong with the brain stem. If you remember, your respiration, your heart rate, your blood pressure, all controlled in the brain stem and the medulla oblongata. If you have a brain stem lesion, if you're on drugs that depress your drive to breathe, we have now decreased or depressed your ventilatory drive. You're not going to have that message being sent out to tell you to start breathing. And we see these patients on occasions, if we overdose them, they're not going to breathe, and they're not going to breathe well. I may have told you this when I was just a very young therapist. Remember, I started when I was very, very young. I went into a patient's room. She was fairly pale. She was a little cool at this particular point. She was breathing about 5 to 6 times a minute. And fortunately, the doctor was there, and I went out and said to the nurse, "We have a problem." And the physician came in to look at her, and he goes, "Well, let's go ahead and do an ABG on her." We did. Her pH was 7.16. He asked, how much sedation did she get? And what had happened was that she had gotten almost twice what she should have gotten. And so she had a depressed ventilatory drive. And so what they had to do was give her the reversal agent to wake her up. If the message is able to get out, the second stopping point is the respiratory muscle failure or fatigue. Respiratory muscle failure or fatigue are your neuromuscular issues. You guys remember Guillain-Barré comes from the ground up, myasthenia gravis from the head down. If you have Guillain-Barré, what's happening is you're becoming progressively weaker as it goes up your legs. Eventually, it's going to end up in your thoracic cavity. Depending on how high it travels, it's going to determine whether or not those muscles are going to continue working, or do we have to, in some cases, intubate you, and hopefully that you're going to reverse this and be able to get off. One of the things that you want to make sure you take a look at is ALS or Lou Gehrig's disease. This is starting to come onto the boards. Not only is it starting to come into the boards, this is something that has been picked up from the Iraqi-Afghanistan war. We're starting to see some of the military folks, retired ones, or the ones who served whatever their tour duty was and then got out. They're starting to have ALS show up. And these guys are on ventilators because remember, what happens with ALS, there's no treatment or cure for it, and so your respiratory muscles eventually are going to give up. If you remember, there's 100% mortality within about 3 to 5 years after you've been diagnosed with it at that particular point. So, if you're going to work around the VA system, or you know somebody who works in the VA system, they can tell you a little bit about it and what's happening to it. But yes, these guys are eventually going to end up on ventilators. They have respiratory muscle failure and fatigue, if you think about it that way. If everything is okay with the brainstem, they don't have a neuromuscular disease or anything that's going to affect the message being transmitted beyond the respiratory muscles, then we're looking at the increased work of breathing. Increased work of breathing is what we see with our patients who have COPD, asthma, anybody who's working really hard to breathe. The problem is, here's the brainstem saying, we need to pick it up. The CO2 is too high. I need you to start breathing more for you. And the work of breathing is sitting there going, yeah, right. And what happens in this case is we're actually going to see the patients start to slow down in their breathing at this particular point. So if you put these together, and we're going to talk a little bit more about them here in just a minute or two, here's basically what happens. You either have a problem with your brainstem, you're not getting the message out, If the message is not getting out from the brainstem, you're not going to have a really good ventilatory drive. If your brainstem is okay and there's nothing depressing it or decreasing it, then the second stopping point is going to be respiratory muscle failure or fatigue. If your patient has a neuromuscular disease, that's a good stopping point. The message is not going beyond that at that particular point in time. If the brainstem is okay and the respiratory muscles are not fatigued or have not failed, the third stopping point is going to be your increased work of breathing. If we're not able to slow your breathing down, have you have a better tidal volume, a better minute ventilation at this particular point in time, then we will also see hypercapnic or ventilatory respiratory failure. If all three of these are working, then we need to see really what's going on with this patient at this particular point. So there's your decreased or depressed ventilatory drive. There we go. Remember, we have the phrenic nerve, which is between C3 and C5, innervates the respiratory muscles, or at this particular point, through the CNS system and allows us to breathe, okay? Remember, too, that when we're breathing, we're going to breathe off our central chemoreceptors unless we have COPD and then some of the neuromuscular disorders for the folks who live in chronic respiratory failure. And remember, the folks who have this breathe off their peripheral chemoreceptors. They're breathing off their oxygen levels, okay? Hello. Let's see if we can erase this. Okay, they don't want to erase it either. Okay. Anyways, let's see if we can get this to come up a little bit. Hold on for just a minute or two. Okay, we're going to see if this will now work. I'm not quite sure. There it is. All right. For some reason, the computer decided to freeze up. I apologize for that. But anyways, we're going to talk about the chemoreceptors. Remember, you have both the central and the peripheral. Remember that if you don't have COPD, neuromuscular, or something else that's going to interfere with your CO2 levels, then you're going to breathe off your central chemoreceptors, which is responsive to CO2. If your CO2 is too high, you technically, if you think about it this way, have burnt off out the CO2 receptors. Now you're going to have to breathe off your peripheral chemoreceptors. Remember, once you hit about 60 millimeters of mercury of PaO2, those peripheral chemoreceptors start slowing down. And this is the reason why we have those depressed ventilatory drive for patients who have COPD, and we don't want to give them a lot of oxygen. So here it is, some of the things that can diminish or decrease your ventilatory drive: drugs, brainstem lesions, hypothyroidism. This is an interesting one. When I was first teaching this, we were talking about this with the students one day, and it was really kind of funny. We were like, hypothyroidism? It doesn't seem that that should have an effect on it. We went and we looked it up, and sure enough, it said hypothyroidism can decrease or depress your ventilatory drive. Didn't go into too much more with it, but that's one of the things that we always have to watch for. Sleep apnea is another one, because remember, the people who have sleep apnea have problems with their breathing. Morbid obesity. Remember, somebody who weighs 1,000 pounds cannot lay down and sleep. They would actually crush their lungs. And these guys have to sit up a little bit to be able to breathe. And it does affect their drive to breathe. And then obesity hypoventilation syndrome. This is another one that we see. Daytime sleepiness. This is also one of the definitions as you go through the word list. You'll find it on, I think it's number 6. For the most part, these can be reversed with treatment, okay? We can give you CPAP, BiPAP, depending on what's going on with you. If you have nocturnal hypoventilation, most of the time we're going to put you on BiPAP because we need you to start breathing also. If we can with the drugs, we can give you the reversal agent. Sometimes though with a brainstem lesion, you're pretty out of luck. Sometimes you can do something about it, but sometimes you can't. We can give you medications for the hypothyroidism, and perhaps you can lose a little bit of weight and help you with your obesity problem. The hallmark of this is bradypnea apnea. Okay, you're not breathing, you're going to stop breathing. And remember, anytime you have apnea for more than 10 minutes, that's pretty bad. And we're going to have to deal with that at that particular point. Other things we see then that go, of course, with this is going to be a decreased respiratory rate and or tidal volume. These guys, the problem for the majority are not PFTs. It's not problems with the lungs themselves. The issue is what's outside of the lungs, and that's where we see this coming up at this particular point. What it is the respiratory muscles don't have the neuromuscular impulse. Therefore, the message is not being sent out. If the message is not being sent out, there's no stimulation at this particular point. Because there's no stimulation, the patient is not breathing. And so what we'll do with these guys is we'll go ahead and put them on mechanical ventilation until we're able to reverse what's going on at this point. And sometimes these guys are on ventilation for a very short period of time. Sometimes they're on them just a little bit longer. It just depends on what the underlying cause is at that point. Respiratory muscle failure or fatigue. These are things like amyotrophic lateral sclerosis or ALS, Guillain-Barré, polyneuropathy, myasthenia gravis is another one. Again, a lot of these are your neuromuscular diseases. So this is ventilatory pump failure, which is a classic definition of hypercapnic respiratory or ventilatory respiratory failure. Again, the CNS controls the function of the lung through the phrenic nerve. And here it is, the message is sent out. The problem is not the CNS system. The problem is the muscles, okay? The neuromuscular dysfunction. And as you can see, this includes the lung parenchyma, respiratory muscles, even the thoracic skeletal muscles. If you have a flail chest, you're going to have a problem with your breathing also at that particular point. So there's some of your muscles that will cause you problems. What happens because of the excessive work of breathing these guys have? The muscles get very, very tired. They get very, very weak. We see an increase in their PaCO2, and their O2 begins to decrease at this particular point. Diseases connected with this can either be very self-limiting or they can be terminal in some cases where they're not going to be self-limiting. ALS is one of those. So some of the bedside measurements, and I'm going to just talk a little bit about these, and then we're going to talk about these a little bit more because they're going to be included in some of the indicators for support, okay? If you remember when you did your PFTs, you guys did your maximum inspiratory pressure or negative inspiratory force, MIF-NIF, same thing. If you remember that, what you did is you told the patient, take a great big deep breath in. Nothing was coming in, but we were measuring the amount of force they had. Normal for this is like negative 80 to negative 100 centimeters of water pressure. And as long as you're somewhere around there, you're doing pretty good. What we use for support required is anything greater than a negative 20 centimeters of water pressure, okay? What we mean by greater, this is a negative number. So if it's greater than negative 20, it's like negative 18, negative 15. If you're in that range that's greater than negative 20, you have a problem, and we're going to have to provide support for you. The indicator of support for the MIP-NIF is anything greater than negative 20. To come off of the ventilator, it has to be less than negative 20, okay? This is what's in the books. You may now go to a hospital and they may tell you that their protocol is negative 25 or negative 30. That is okay. That is hospital specific, okay? But when you look in your book, it's going to be greater than negative 20. Maximum expiratory pressure is right around 40 centimeters of water pressure. If you're having problems with that, that's another one that we could also look at. Forced vital capacity. Remember, this is where you take that great big deep breath, blood out as hard and fast as you can, and then we're going to go ahead and measure that for you. A normal forced vital capacity is 65 to 75 mLs per kilo. A normal forced vital capacity, if you're doing PFTs or your PFT calculator breaks and you have to figure out your forced vital capacity, it is 65 to 75 mLs per kilo. Okay, and the kilos come from your ideal body weight. And this is one of the things we're going to use to determine whether or not a patient needs support. In this case, we're going to drop down all the way to less than 10 mLs per kilo. If you're less than 10 mLs per kilo, that is an indicator for support. If you're greater than 10 mLs per kilo, you're still going to have to be watched because that's very, very low. I think we're in the process of heading back to the 10 to 15 mLs per kilo. Hasn't hit the books yet, but I'm hearing rumblings here and there that it may end up in there, okay? I'm going to jump over MVV at this particular point. If you have a patient who's tachypnic and now they have bradypnea and apnea, they got some problems. We need to do something to help them. Respiratory alternance, this is where you alternate the use of accessory muscles. You'll see patients doing this. They'll use their upper, the sternocleidomastoid, mastoids, and all those, and then they'll stop, and then they'll start using their intercostals at this particular point. And what they're doing is they're resting one set of the accessory muscles, and then they use the other one, and they go back and forth. This is a pretty late stage. This is something that should have been caught before they ever got up to that point, okay? So we need to really watch these patients and see how are they breathing. One that's kind of interesting too is the sniff nasal inspiratory pressure. They're using that now. If you sniff, you can feel your diaphragm moving, and that's what we're doing with that at that particular point. With the MVV, remember that's that one where you're going to breathe hard and fast, 12 to 15 seconds. You only wanted to do it once because you're going to pass out if you had to do it again. Well, think about somebody who's breathing 30 times a minute. Doc comes in and says, hey, let's go do an MVV. You sort of have to look at him and go, very politely, very professionally, are you serious? Because there's no way this person's going to breathe much faster. And if they try, make sure you have a ventilator and a code cart with you, okay? Because that's something that you're actually going to need at that particular point. And then the last one, this is your increased work of breathing. We're looking at an excessive workload the muscles can't handle or respond to at this point. We see this with our patients who have COPD, our patients in the middle of acute asthma, other things, broken ribs, pneumothoraxes, pleural effusions, some major VQ mismatches, different things along that line. We'll see that at that point. And so what we see with this one too, it's excessive ventilatory workload. The message actually got out of the brainstem, actually made it through the muscles, has now arrived at the muscles to try to continue to have them work. And what's happening is the muscles are tiring at this point. They're way overtaxed. They can't do anything. And so we're going to start seeing our patients slow down. So there it is, common causes: acute airway obstruction, increased dead space, heart disease, congenital heart disease is another one, thoracic abnormalities, shock, increased metabolic rate due to increased CO2 production. These are some of the bigger ones with it at that point. Okay, the slide just decided to go away. But here it is. This is some of the causes of problems with our patients: chest wall elastic problems, lung elastic wall problems, different things like that. So these are some of the things that are going to go ahead and affect either the brainstem, the respiratory muscle failure, fatigue, or the increased work of breathing. Now, one of the things I want to mention to you, you see this little thing in the middle here, this little drawing. Let me grab my pencil here. It's not working quite like it should, but that's okay. You see that we talk about load. What load basically means is, are you able to carry the load to continue breathing as you need to, okay? If the answer is no, and we're going to provide you support, what we're going to do is unload your muscles, and we're going to give this work of breathing to something else, okay? Once you're better and we're going to be able to stop the support, we're going to reload your muscles with the work of breathing. So if you hear or you read something, and of course you'll hear or read it from me, if you have an excessive workload and you're not able to carry your breathing as you need to, and you're in respiratory failure, we're going to go ahead and allow you to rest. We're going to unload your muscles, give the work of breathing to something else, for example, a ventilator. Once you're much better then and ready to come off, what we're going to do then is reload that work of breathing onto your muscles at this particular point. Okay? All right. This is actually a very good stopping point. I'm going to, if you look into your notes, you'll see that there's a review for Friday's quiz online that will be due as part of your class work for today. Go ahead and do that review. You also have a worksheet that has some problems that have to do with the classic shunt equation. Those will be due by Friday. The classic shunt equation is not on your quiz, so therefore I'm not in a big hurry to get it, have you do it at this particular point in time. I want you to remind you, if you have questions, you can call me, you can email me. Either way, I will get back with you and explain anything that you need at this point. Hopefully, too, at this time, I've sent you the recording from the third lecture, one we did on Monday. And if you have any questions about that, please let me know. Thank you.